Everyone. Today I'll be talking about corneal biomechanics. So corneal biomechanics is basically the study of cornea to an external force, and cornea by its nature exhibits properties of both viscosity and elasticity, and all viscoelastic materials demonstrate a property called as hysteresis, which is basically a differential response during a loading and unloading response. In terms of corneal hysteresis, it is the ability of cornea to absorb and dissipate energy, and it is basically a dynamic behavior of cornea. So does corneal mechanics make any difference? Especially when you are looking at eyes which have a risk of ectasia, these eyes usually go through various phases before landing up in an ectatic phase. Basically, there is a change in the biomechanical properties, then there is biomechanical weakening, followed by tomographic and topographic changes. Finally, you manifest all these signs on a slit lamp. So it's very important to identify these eyes which are at risk of ectasia at its earliest point. So the current standard of care with most of the surgeons is they look at the corneal topography or tomography map and then the aberrations. Based on this, we usually decide the surgical procedure. But there are very few subset of corneas which usually land up in ectasias because of biomechanical weakening. It is very important to identify these corneas which might land up in ectasia. So by including corneal biomechanics in the routine evaluation process, you can identify those biomechanically weak corneas and then select an appropriate procedure which would result in uneventful surgeries. So there are various ways by which you can measure corneal biomechanics. The ones which are usually feasible are the in vivo methods such as the ocular response analyzer using Corvus and the Brilon optical microscopy. So there are few biomechanical properties that have been demonstrated with ex vivo technique. That is, there is a non-linear stress versus strain response. That is, at a lower strain, it has a non-linear relationship, and at a higher strain, it is more of a linear relationship. And the cornea, that is especially the peripheral and the mid-peripheral cornea, is slightly stiffer than the central cornea. The cornea, it stiffens with age, and the anterior 40% of the cornea is more stronger than the posterior 60%. Ocular response analyzer, this was the first instrument that was introduced that could measure the corneal hysteresis. Basically, it contains a air puff tonometer which causes a corneal deformation. This deformation is picked up by the infrared emitter, and then it is depicted in the form of a graph. There are various measurements which you can get with ORA, that is the Goldman's applanation IOP, Goldman's correlation IOP, the corneal compensated IOP, the central corneal thickness, corneal hysteresis, and the corneal resistance factor. But there are few limitations with this, with the ORA, that is there are discrepancies from the expected results. The ORA waveform analysis alone does not suffice, and CRF, that is the corneal resistance factor, is dependent on corneal thickness rather than the corneal stiffness. Another way of studying the viscoelastic properties is by Brilon optical microscopy, which is basically, it depends on the Brilon scatter. So whenever there is an interaction of incident light with acoustic phonons, which are nothing but atoms in vibration, there is a shift in frequency. This shift in frequency can be measured by a spectrometer, and then the shift in frequency is then converted into an elastic modulus, which gives us the elasticity of the cornea. So this is image taken from a Brilon optical microscope, and the various layers and how these are how the viscoelastic properties of each layer is. Coming to Corvus, this is the latest and most reliable and consistent way of studying the corneal biomechanics. It consists of an air puff tonometer, which usually projects an air puff onto the cornea, and this air puff usually causes a corneal deformation, resulting in an ingoing phase. Then you have a highest concavity phase, undulating phase, and then the outgoing phase. In the Corvus, you get a display called as a DCR display. It's a dynamic corneal display. On the left-hand side, you have the various parameters such as the amount of deformation, the highest concavity, the first and second applanation which the cornea undergoes during this bidirectional applanation process. And these are mapped against time. And the softer corneas usually have a higher deformation amplitude ratio. The indicated radius is higher, and the ARTH and the stiffness parameter at first applanation is usually lower. And for the stiffer corneas, it is vice versa. So the corneal deformation response, this is a corneal deformation response in a normal cornea. You see the ingoing phase and then highest concavity. This is followed by an outgoing phase. This is a comparative video of a keratoconic eye with a normal eye, where you can see the deformation is more, the applanation length is less, and there is more of undulations at its highest concavity. And similarly, in a keratoglobus, you can see the amount of deformation that a cornea undergoes. Corvis can also be used to compare the pre and post C3R effect on the cornea. In the post C3R corneas, you can see that the deformation is almost the same, but the undulations and the stability of cornea is slightly better. Vincingvera report is a screening report which is similar to the bad display of pentacam. Here you can see the various parameters such as the deflection amplitude and the deformation amplitude plotted against time. One important parameter which the Vincingvera screening report gives is the stress strain index. It basically tells us the stiffness of the cornea. The corneas which are having SSI less than 1 are usually stiffer, and towards the right the softer corneas. Corvis biomechanical index, this is another parameter given in the Vincingvera screening report. It is basically a linear regression analysis of the 4 parameters that is taken, that is the deformation amplitude ratio, integrated radius, ARTH, and the stiffness parameter. Here the zone in the white is the one which is there in the 2 sides of the standard deviation, which is within the normal limits. The other display is the ARV display, also called as the biomechanical display. Basically, it combines the data taken from the Corvis with that of the pentacam to give us a value, that is the tomographic biomechanical index. So CBI and TBI more than 0.3 is considered to be suspicious, and more than 0.5 is abnormal. So there is a entity called as the CBI LVC, that is the machine automatically detects eyes which have undergone surgery, and CBI post LVC is a value which helps us in assessing the biomechanical stability post operatively, and it also estimates the risk of ectasia. So this is one case scenario, a patient who has come for a refractive surgery opinion, and this is the subjective refraction. If you look at the 4-map refractive display, all the parameters are within normal limits, and also the bad display which is within normal. When you look at the Vincingvera screening report, the CBI is around 0.04, which is again within normal. SSI is less than 1. So the ARV report, it also shows the TBI is almost close to 0, which is again within normal limits. And for this patient, a routine smile was planned with the residual stromal bed thickness, which is more than 300. This is an interesting scenario where you can see the subjective refraction was around -3 and -2.5. The 4-map refractive looks normal, but the corneal thickness is slightly at the borderline. And the 4-map refractive is also, the bad display is also normal. But when we look at the Vincingvera screening report, the CBI is almost 0.75, which indicates the cornea is slightly biomechanically weak, and also the SSI, which is usually more than 1. And the ARV report here also, it's basically the TBI is little suspicious. And in this patient, we have done a smile extra procedure, even though the residual stromal bed is more than 300. This is mainly because of the biomechanically weak cornea. There's a new display which has come with Corvis, that is the comparison display. Here basically you can take measurements at 2 different points and compare this Corvis biomechanical properties. That is, the blue is at one time point and the red one is the other time point. And you also have a video which you can compare the deformation response. And these are the various parameters that are plotted between 2 measurements. And you can also see that the SSI, here you can see whether the cornea has become stiffer or it is the same or it has become soft. So this has been improvised as the best display. This mainly helps in monitoring the biomechanical stability over time. You can basically measure the stability of corneas after laser vision correction or else after doing C3R. And you also have a keratoconus staging in this display. So apart from the Vincingvera screening report, which can be only used for screening and for pre-laser vision correction, this can be used for post-LVC eyes also. To conclude, Corvis helps in screening patients for refractive surgery and also helps in selecting the appropriate procedure. You can monitor the biomechanical stability of the cornea after laser vision correction and identify those eyes which can land up in post-LASIK ectasia at its inception. And you can monitor the progression and also verify the success of C3R in keratoconic eyes. And it also helps in screening patients for glaucoma. Thank you.
Thank you, Dr. Raghavendra, for that very elaborate talk on Corvis and showing all those nice examples where tomography looks completely normal, topography is normal, and I think the main utility of Corvis is identifying those corneas which look topographically normal, but the intrinsic factor of biomechanical strength is something that we can only study by a Corvis or any other biomechanical measurement device such as the Brouillon microscopy. So thank you for explaining all these concepts in such a simplified way.